Good afternoon, everybody. I'm Dave. Like the kind of introduction, I'm at Dallas at UT Southwestern Medical Center, and I'm going to be talking to you about the role of clearance mapping and surface-guided in treatment planning. So, here we go. So, since clearance mapping and surface-guided is relatively new, I'm going to explain what MapRT is first and show you what it looks like in our simulation vault, and then how you would interact with it in the system. And then I'm going to make a pitch for you why it's important in modern radiotherapy. So this is coming at the aspect as if you're not doing a lot of non-coplanar treatments currently, and how this could enable you to do it from a dosimetric standpoint. I'm then going to look at how we did our initial implementation and compare it to our current old school method of doing dry runs on the machine with the patient's immobilization equipment. And look at one of those case examples and how much time you can save by using service guided, and then summarize the talk. So what is MapRT? So it's currently a prototype system that we've been testing with VisionRT at UT Southwestern, and another center in Regmore in Scotland has also been testing it. And it's essentially taking a snapshot of the patient at simulation in the treatment position with their immobilization as shown on the left image, and then registering that to the couch table for treatment. And you can see here we have a LiDAR scan of the TrueBeam system from Varian. So in the simulation vault, we have some more cameras now. So MapRT uses 2 horizon cameras that are lateral to the couch top. And we also have SimRT, so that looks a lot like your traditional LineRT system in a treatment vault. We have an additional monitor that we have in the console area and also in the vault area. And we found that the vault area is actually the best place for it, because that's when you're actually moving the patient and positioning to take your capture. So the 2 monitors are side by side for the 2 systems in our vault, and we have 1 keyboard and mouse that you can toggle between to control both systems. So it's set up on a rather small counter in our vault due to limited space, like I assume most people have. So a little video showing how this interfaces. So here's an example of one of our larynx patients that I'm taking that capture from their sim and placing it on the TrueBeam system that they would be treated on. Then, once you say I want to generate a collision map for that surface and that particular machine, you can then import the DICOM plan and look at how the clearance map might look like for that selected geometry. In this case, we have the DICOM on the left, which there's 3 arcs, 1 coplanar at couch 0, and 2 half arcs at 30-degree couch kicks. And you can see that here in the middle plot. We have what that would look like, where couch is the long axis or horizontal axis, and then gantry angle is the vertical. And then we have our clearance zones, or areas of collision. And you can see that our current plan is navigating between those. There's a lot of extra space that this particular plan could use, but we also are gating off of the larynx during treatment, so we don't kick the couch too far for that treatment for that reason. And then lastly, you have an interactive space where you can zoom in, pan, and look at the different aspects of the capture and the treatment. Then to show you what that would look like if you're interacting with it, we can virtually navigate that space, looking at how that arc would go if you were to treat it. And then going to the next one, and you can see like clearance is not an issue for this particular treatment. But if you were to get crazy, what would that look like? So now I'm going to move the mouse way over into one of the collision zones, and indeed, I would be colliding in gantry with the patient's pelvis. And we can move that through the clearance zone and see that even though that arm is fairly close to the gantry, it is something that we can readily treat with at couch 0. So that is MapRT. It's a clearance mapping software that you can use from captures you take at the time of simulation. Now, why is it important? So that's a big issue. Why would you want this in your clinic? And to do that, I'm going to show you why at UT Southwestern we think this is something you really need. So I'm just going to give you some history about UT Southwestern. So we opened in 2006, treating 1,200 patients a year. which is actually the year I graduated high school. Fast forward to the present, in 2023, we're now treating 4,000 patients a year. So pretty steady growth over those decade and a half. How we've done this growth is really by decreasing the number of fractions the average patient will get during their course of treatment. So back in the day, it was in the mid to low 20s. Now it's 12 on average. Aside from adding a few new vaults, this has really driven the growth that we see. And you can probably guess why this is. This is a plot showing as a function of year, how many patients have been treated using conventional fractionation versus stereotactically, either with SRS or SGRT or SABR. And you can see my last time point is 2018, in which more than 50% of our patients were treated stereotactically. I would hazard a guess that at the present, that's almost 60% now. So stereotactic is the driving force of our center. Now, stereotactically, we have to think a little bit differently about how we treat these patients. So taken from our chair of the department, Robert Timmerman, this is how you would think about SBRT or SABR planning. So you have to respect tumor coverage and dose compactness. These help characterize your SABR treatment. So that means you have a very highly conformal treatment with a very, very sharp fall off. So in terms of planning metrics, we usually are thinking about your conformity index, either conventional or hepatic, the gradient index, which is the ratio of the 50% of the prescription dose to the 100% of the prescription dose that the patient receives, and then a D2CM. So that's taking the target volume, expanding in 2 centimeters out of direction, and then looking at the maximum dose going outside that sphere. And together, those 3 things can characterize most plans. What that means, though, for SABR is you're giving a lot of beams and coming from a lot of different angles to spread out that dose. Essentially, you're trying to create a plan with isotropic fall-off. To most of you, that's probably common sense. But again, approaching it from someone that is mostly doing coplanar treatments. And we can look at how that affects the dosimetry. So here we have a standard lung SBRT or SABR plan, planned with 2 coplanar VMAT arcs. And what I really want you to pay attention to is that light blue 50% dose isodose line. And again, we're looking at the gradient index of D2CM, so ratio of the 50% to the 100% of the volume. And for this plan, it's 4.6, and 57% is going greater than 2 centimeters away from the target volume. We can then expand that and look at if you took one of those coplanar arcs and made it non-coplanar, how that would affect the treatment. You can see axially the 50% of the dose is starting to compact and expand a little bit more sup-inf, but gradient index hasn't really improved much. We just decreased the spillage outside of that 2 cm sphere. And then we can go to the extreme, which is our standard of care for lung SBRT, in which case you're using 3D conformal beams placed at a wide array of couch and gantry angles. And now you can see how that blue isodose for 50% has really started to compact and spread a little bit more isotropic, or spread isotropically in its fall off, in which the gradient index has decreased to 4.4, and 50% of the dose is within that 2 centimeter sphere. So hopefully that's my pitch on why you want to do non-coplanar treatments, but the risk of doing that is you open yourself up for collisions. And that's where MapRT would come in to give you that confidence to do these treatments. However, we didn't have MapRT until recently, as it's a prototype system. So our initial implementation was compared to what we do currently, which, like I said, is dry run by the therapist on the machine using the patient's immobilization. So you don't have the patient in the vault, you just have their immobilization. So when we wanted to compare how well this system's working to what we do, we went back to our baseline. So we had 30 patients treated with SABR or conventional brain. All of our conventional brain patients are also non-coplanar treatments. So we had the therapist do their standard of care dry runs on the machine, and then compared those results and feedback that they would give to the dosimetrist for MapRT, and also recorded how much time you would be saving both in the vault by using that resource for the therapist to do the angle checks, and then how long the dosimetrist would have to wait for that process to occur, to know that their plan, which they think is a good plan, is a safe plan to treat. So, not dragging out much, we have the therapist dry run and results at the top, in which 29 out of 30 were exactly as we expected, no collisions with the patient. However, because you don't have that patient in the vault, you can't know every aspect. You're using your best judgment in some scenarios. And we'll look at why there was one case, in which case we were wrong. We would have collided with the patient. And then MapRT, 100% agreement with what reality shows when we went to treat that patient. So just to show this example of where we guessed wrong using our standard of care, we have a conventional brain treatment treated on a pituitary board, and you can see the patient's quite broad. Now, when the therapist goes in to do their angle check, they just have the mask and the vac lock bag going to support the neck. They don't know that the arms are way out there hanging off the table. So, but we open up MapRT, select the patient's capture, look at the collision zones, and you can see on the Versa HD, that safety ring that's telling you stop the gantry, you're about to hit the patient, actually would be hitting the patient's arm. In this scenario, you have some wiggle room, you can ask the patient to move their arm, but you can imagine how, if this was slightly more, you may have to abort the treatment and postpone or replan. We can also then look at the time savings, which for us, when we're treating 4,000 patients a year, is a big deal. So here's a plot showing the number of angle checks on the vertical and the time from when the dosimetrist requested it to when the angle check was done in the vault, in which case the black dashed lines show you a clinical day. So on average, we're pretty quick at these. We do them every day, with usually several a day. So the average waiting period from dosimetrist knowing the plan is a good plan to a safe plan is about 4 hours. But you can see there's some which go into the next day, and some that even go into the next day in terms of the back and forth of what is a safe plan. Also, we can look at the time savings of the in-vault. The in-vault time is a resource that you could be treating patients in. So on average, not on average, in total it was about 300 minutes to do all these dry runs. So dry runs, it doesn't sound a lot when you're saying 300 minutes for 30, but if you actually break down the time, that's 5 SABRE treatments in our center or 20 conventional breast treatments. So you're taking cancer treatment time away to do these dry runs when you could be doing it virtually. But let's look at one of these extreme examples on how this really drives home the point of that you're really saving time. So our case example. So here we have a 60-year-old female with a 40 cc right lung lesion. Not really around in the center of the lung, pretty straightforward to treat. So she was selected to do 54 gray in 3 fractions, pretty potent dose. And we're gonna do our 10 field approach. So we can look at how this timeline unfolded for this patient. So back in September on the 16th, we simmed the patient in the afternoon. We're gonna treat them a week later on the 23rd at 1 p.m. MD was on their game, contours ready by the next day. So time to begin planning. For our lung patients, just as it's evolved with time, we have more or less a class solution which we'll start with. So if you're right lung or left lung, here's typically the couch and gantry angles you use for that treatment, which you'll then move for collision issues or to avoid entering through critical structures like the spinal cord, esophagus, heart, etc. So the dosimetric criteria you're trying to use in your plan. So weekend occurred, still dosimetrists finished their plan by the next day. It's the end of the day now, so when they submitted their angle check, it's 4 p.m. Well, the therapists went home. The clinic ended early. So now you're bleeding into the next day. Plan's done for all intents and purposes, but we still don't know if it's safe to treat. Therapists find a slot during the day to do that angle check, taking 10 minutes out of a treatment slot. And by 10 a.m., they say, we have a problem. So for this particular plan, there's 2 angles they think for coach and gantry combinations that will definitely collide with the patient. And when we take a cone beam, we won't be able to clear all the way around. So it's time to panic. We'd lost essentially half a day by waiting. But despite that, the dosimetrists submitted their next revised plan with that feedback for 5 p.m. Again, end of the day. So now we're into the next day. We're coming much closer to that treatment slot. And you can see like they couldn't find a slot in the morning. So now you're at 1 p.m., the day before treatment. You're going to treat the patient the next day. You finally know, is my plan good? In this scenario, yes, all the revisions that the therapist suggested to the dosimetrist turned out to be good on the second review. However, now it's 3 p.m. Everything's finalized in our record and verify system, and now it's time to have the MD, well, track down the MD usually, to sign the prescription, sign the plan, have physics do their chart check, have therapy do their chart check, and do SGRT QA. And assume nothing goes wrong because we're going to treat the patient next day. So instead, we could have done this 2 days ago, and we would have had tons of time to fix any provincial issues that could happen. But let's look at that in MapRT. So if you had the collision space available and you knew it ahead of time, you could load that plan in there and see what it looks like in your collision space. And that's what I did. So I recreated the original plan and said, okay, let's load it in, select the machine, select their scan from SIM, and immediately see there's 2 angles that are of concern. The same 2 angles the therapist said could be an issue. And we can see that moving the couch isn't really going to change the collision space. What we need to move is the gantry. So we want to slide those 2 angles up closer to gantry 0. And we can show how quick that would be. So I may be a little slow in the video, but you can see here I moved it up 15 degrees for that potential collision, taking it outside this collision space. The crosshair is really indicating where it's going on the collision map, and then the color change of the gantry. So I'm happy moving that 15 degrees for the first one and 10 degrees for the second. So with that information in mind, redid the plan, sent it back to MapRT, and I get the same results as 2 days of replanning and redoing collision checks. So that, for me, took a matter of minutes. So going from almost 2.5 days of waiting to several minutes. And again, this is 51% of our patient volume, at least. So, to summarize, MapRT is a novel SGRT clearance mapping software. It's more accurate in manual angle checks because you know what the patient looks like. You're not guessing. You're not using photos someone took at SIM and saying, I think their arm is here. Maybe it will clear, maybe it won't. And for us, the biggest thing is how much time it's going to save our clinic. As you saw, on average, 4 hours of savings, but that can be days in terms of getting that plan done. So in short, if I had to put it in a sentence, MapRT or any collision mapping software gives you the confidence to do non-coplanar treatments, which in the opinion of UT Southwestern is how you do SABRE treatments in a safe way. Of course, I'd like to thank all of the people at our center that helped test this prototype and provide the feedback through its development. So thank you.